So let me focus on the very crux of the lateral mass fixation and go it very fast, and including a short cadaveric demonstration of that simple procedure. Now, let me tell you all that the delegates and the residents about this technique is the simplest of these instrumentation procedures anywhere done in the whole of the spine. So, I mean, but having said this, the simplest procedure, it is it has to be done in a meticulous and the recommended way, otherwise it can turn out to be a disastrous fixation technique if someone does not do it in the right way. So I will start it from here, and the surgical technique I will focus it on more rather than the theoretical aspects, because one needs to know as to how to do it rather than about the theoretical aspects of this technique. So obviously this is done in a prone position, and head, you may fix it in the Mayfield pins, or you can place the head in a head holder. Well, what if you ask me, I prefer generally Mayfield pins because there are concerns about eye pressure if you use a head holder. And cervical spine, the position of the cervical spine, well, it depends on mostly on the build of the patient. So generally, I avoid doing too much of a flexion or too much of an extension, especially the extension is to be avoided at all costs, because if the ligament flavum hypertrophy or the posterior compression is there more in a CSM patient, in a cervical spondylotic myelopathy patient, then what happens is in extension, the ligament flavum gets buckled up, and that can press or pinch on your already compressed spine, and then you can have problems in the post-op or immediately if you are neuromonitoring your patient during the surgery. And always, if you ask me, I always do neuromonitoring during my all spinal operations as a routine standard protocol. So a midline and linear incision is given, and after that you do the subperiosteal dissection of the neck muscles, posterior neck muscles, bilateral exposure of the lamina entirely down laterally to the entire lateral masses. Mark the entry point as per the landmarks, and how you do that I will show you in the video and subsequent part of my slides. Tap the screw holes and then insert the screw. So this is how as simple as it is, and various ways of doing this have been mentioned in literature. If you read the textbooks, there have been several techniques, Roy Camille, McGill, and technique. So depending, they all techniques do differ from each other regarding the entry points and the directions and of your screw. But they're very difficult to remember. I mean, but some say 10 degrees, some say 20 degree. What I find suitable as a surgical dictum is that you follow your spinous process of the lower vertebral body. Number one, my one technique is to you follow the spinal direction of the spinous process of the lower vertebral body, and the cephalad angulation of your screw will be along the direction of the spinous process of the lower vertebral body, and it will never go wrong. As far as the lateral trajectory is concerned, it is always 25 degrees laterally. And during surgery, what you do is, another thing which you can do is you insert your number 4 dissector into the facet joints of the lateral masses that you intend to put in your screw, and then follow that direction of the cephalad direction parallel to the direction of the facet joint. So these are two surgical points which you can always remember. You can never forget ever in your life when you're doing this simple procedure. So if you ask me personally, I don't remember these Roy Camille, Major technique, or several hundreds of techniques which are mentioned in the textbook. They're good for passing out the exams, but real exam is daily, on a daily basis, when you do the surgery on a patient and your patient comes out safe out of the operation theater. So this is a surgical trajectory which I call, and it will never fail you. So generally the trajectory and the entry point is about some. Now, this is a summary, some point of, I don't have the time to explain all of these procedures, the entry and the trajectories, But if you summarize all of these, the entry point is, what you do is you dissect the lateral mass. I will show you in the cadaveric video, and then make a square, demarcate the square with a ball pen, with a sketch pen. So it will be a square, and then divide that square into 4 parts. And the entry point will be about 1 millimeter inferomedial to the center point of the lateral mass. I repeat, the entry point is 1 millimeter inferomedial to the midpoint of the lateral mass. This is the entry point, and the direction is 25-degree lateral, and the cephalad angulation follows the either of the 2 planes, either the facet plane or the direction of the spinous process of the vertebral body lying just inferior to the lateral mass you are planning to screw. So this is about the direction and the trajectory. The dimension of the screw is, generally we use 3.5 millimeter to 4 millimeter diameter cortical screws. And well, it depends upon the many things. It depends upon the habitus of the patient. It depends on the bone stock of the patient. It depends on how strong is the lateral mass. And generally, I prefer 3.5 millimeter to 4 millimeter diameter screws. And the length is 10 to 16 millimeter, which is again dependent on the volume of the lateral mass. So generally speaking, if you ask me, 14 millimeter is the desired screw length, and this achieves bicortical purchase in 92% of the cases. So lateral mass screws, it is generally said that bicortical purchase is an ideal purchase, and because this gives you better biomechanical strength and greater pull-out strength. So showing you a short cadaveric demonstration, and this was the video which we developed when I was doing the cadaver training and research facility at All India Institute. And this is a short 1 minute 45-second video. So let me orient you before I start this video. Well, this is the head side. You see my marker over there? This is the head side. This is the leg side. And this is the patient is lying prone, and this is the patient's right side, and this is patient's left side. So you start by exposing and dissecting the musculature of the posterior neck subperiosteally, and then you expose your lamina spinous process down laterally as far as the lateral masses, and you will find laterally the lateral masses to be a squarish structure if you view it from above. Howsoever, it is a rhomboid structure which is located on the lateral aspect, and it forms the facet joints of the subaxial cervical spine. So once you have dissected the muscles, then your job is to identify the lateral masses and demarcate them. Now this is what I'm doing with the cautery, the dissection, and you do the dissection as laterally as the lateral mass dips in on the lateral sides. So this is where you have to stop your dissection, and once you have demarcated all the lateral masses like this. So this lateral mass starts from here laterally. This is the inferior portion. And what is happening? Why this is running again and again? So I was saying that this is the lateral mass. You demarcate it with a pen, and then you divide this lateral mass into 4 equal quadrants. This is the lateral mass, and you take the center of this lateral mass here, and this is what I'm doing. I am demarcating this lateral mass with my cautery here, and then drawing the midpoint of this lateral mass, which lies approximately here. And then you make a trajectory with the C1 drill. With the C1 drill, you mark the entry point. The direction is the same as I told you in the before, 25-degree lateral, and about the cephalad trajectory. It follows the direction of the facet joint. And generally, I keep the length of this drill to be about 14 millimeter. And you have to be very gentle with these lateral masses, especially if the stock is poor or the patient is osteoporotic. And most of these patients are osteoporotic patients of elderly gentlemen. So you have to take care. At any point of time, do not have to use your force. After you have made the trajectory with a C1 drill, then you take a tap, which is generally of 2.5 millimeter. And then with the tap, you palpate that. When you have made a tap, you palpate that hole with the sound and palpate all the five margins of your screw hole, the superior, the inferior, the medial, the lateral, and the depth. So and after that, you take an appropriately sized screw, about 3.5 millimeter to 4 millimeter in diameter and 14 to 16 millimeter in length. And then the tip is here, the technical tip, which is not generally mentioned in the textbook, is when you start inserting your screw, you do not have to take that direction, straight direction. No, you initially what you have to do is you have to take 1 or 2 turns of your screw straight like that, so that it engages into the cortex, and then turn the direction which goes into that screw hole. So this is what, and nowhere, second point is that nowhere, as I already mentioned, you have to use the force while putting in the screw. Otherwise, what will happen in osteoporotic patients, this lateral mass will give way and fracture out. So it is a helpless situation that you are in actually at that time. So this is how you insert the lateral mass. See on a image here, this screw should be parallel to the facet joint, and it should not cross the facet and body junction, slightly protruding from the facet and body junction. So this is all this is a technically straightforward technique, user-friendly technique, as I already mentioned, and can be used for a variety of indications where you are doing a laminectomy and fixation, mostly in cervical spondylotic myelopathy and prone on a Mayfield. Exposure of the whole lateral mass is mandatory before starting this procedure. First of all, demarcate your lateral masses. After you have exposed them, mark out the entry points, then drill, then tap, and then insert the screws in the same manner which I told, and use contoured rods for maintaining the cervical lordosis, and do a laminectomy whenever it is indicated. Thank you.